Thank you so much, Alberto. So now we do have a patient that was screened. He had a suspicious MRI. We found cancer. And now do we need any more tests? Are genomics helping us to really better prognosticate the patients? Should we spend money before we are talking about therapy? Gerhardt Attard from London is speaking to this. I'm looking forward to your talk, Gerhardt.
Thank you. I'm a medical oncologist, and I've never spoken in a panel on screening or diagnosis. I told Vera this just before the session, and he said, "Well done. You've worked hard to get to this point." So if I understood you correctly, Boris, your aim is to eliminate biopsies, which will, of course, cause a problem for people like me who are working tirelessly, I'd say, to use molecular information to influence our decisions. So maybe we can debate that before you're successful in eliminating biopsies. Now, as a medical oncologist, I'm going to introduce a slant in metastatic disease. I know there's going to be several good talks about molecular risk stratification in localized disease, but I'm going to try and cover the whole spectrum. My disclosure slide, I do have a disclosure that's relevant to this talk. We have a collaboration with Veracyte and UCL, which is where I'm employed, could gain commercially from that. My talk is going to be more like a film trailer than a mini-series, a lot of snapshots of parts that I think are exciting, set the scene. You know, in reality, especially in Europe, we're not using molecular tests, at least not as widely enough as I think we could. So I'm going to go one step by step. Let's start with tumor DNA sequencing. And 10, 15 years ago, we got this molecular taxonomy, where if you look at the top rows, all cancers fall into these neat groups that are defined by a genomic event, which is mutually exclusive. So ERG rearranged, ETV1 rearranged, SPOP FOXA1. There's limited intra-patient heterogeneity. And if you'd asked me to bet 15 years ago, I'd have said we're categorizing everyone into these groups and using that to decide who we should treat and how we should treat. But it hasn't really panned out. In terms of risk stratification, genomic testing for these lesions isn't really too informative. SPOP do well, and there are very few of them in metastatic disease, as I've implied. We're not using that. And FOXA1 looks much more complicated. And the recent publication suggested there are some mutations in FOXA1 that are associated with good prognosis, others that are associated with bad prognosis. So that will explain the sort of confused literature in that regard. What's been used primarily in terms of genomic analysis for risk stratification is testing for recurrent mutations or deletions or alterations that, when you group them up, associate with worse prognosis. And the main focus has been on TP53, P10, and RB1. And RB1 is clearly more common than you can in advanced cancer than you can see in this TCGA data set, which included a lot of early cancers. And several publications have shown that if you have one of these, let's call them tumor suppression genes, which is altered, that's worse than none, and 2 or 3 is worse than 1. I'm not convinced that's going to work, and I'm going to talk through in the next slide, but of course BRCA. So BRCA2, I'll refer to this in the germline section, but that's clearly an event which is associated with worse outcome when patients have mCRPC. We'll talk about localized disease in a couple of slides. So, you know, should we be testing for specific molecular alterations to assess risk or prognosis? And what we tend to see is that the more of your genome is altered, the worse you do. And that is relevant in early patients, but it hits a plateau quite quickly, and that's what this shows. So at about 5 or 6% of the genome having an alteration, then it doesn't make too much of a difference whether you have 2, 3, 4, 5 alterations. And I think cherry-picking single common alterations has basically captured this picture. Now, there are many challenges in testing tumor DNA. And that relates to the size of the biopsy material you're providing for us, the way it's being processed in formaldehyde. That has a high failure rate, especially when we test these several years after they're collected. Because of that failure rate and this chance of false calls, our pipelines are really strict. And that results in a high risk of missing events. So I'm pretty confident to tell you there's a BRCA mutation in a tumor sample when I've analyzed it. But can I really be sure there's no mutation or there's no deletion? That false negative is real. And of course, there's undersampling, that single biopsy. And I've just alluded to misdeletions. Ascertaining whether there's loss of a gene, especially if it's subclonal, in a sample which is formaldehyde treated with very low tumor DNA and where the tumor purity may be 20, 30%, is really close to impossible. I'll just mention P10. Those of you who are at GU ASCO may have noticed there's a P10 advert everywhere. I'm not sure what it was about, but I suspect it relates to the Capitello trial. AstraZeneca will, I guess, present soon that used patients or selected patients with P10 loss by IHC for treatment with an AKT inhibitor. We don't have data on that trial, as I've said, but very timely is the recent final overall survival analysis from the Hypertension 150 trial. And the indication from this is that an NGS-based assay is giving more information, at least in metastatic patients, than IHC. And we have some cool data from Stampede we're going to present at ASCO that suggests IHC is prognostic and localized, but not in metastatic disease. I think there's a lot to tease out with regard to P10. Germline testing, I alluded to this. If there's one test you do, it needs to be BRCA. For very high-risk patients and M1 patients. Clearly, it's prognostic. It also has the benefit of cascade testing. I'll also mention one other germline test, which is quite exciting, which are HSD3B1 polymorphisms that result in a hyperactive enzyme, which results in increased synthesis of androgens. And this could result in resistance to ARP addition to ADT. So the red line are patients who received ADT and an RP or a combination RP, but did not have the enzyme, whereas the patients who had the hyperactive form of the enzyme are the yellow, blue, and green line. So more work to be done here, but keep your eyes on it. I'll focus mRNA profile discussion on metastatic disease. I know Dan's speaking about localized disease later. So this is data from about 1,500 patients with very advanced metastatic disease. And when you look at the whole transcriptome, you, at least expression levels, you get lots of information about biologically relevant pathways. And I'm going to focus on Decipher because that was really the main primary question we asked. We had a predefined statistical analysis plan that sought to test both the prognostic and the predictive utility of 3 signatures in metastatic or high-risk locally advanced patients receiving docetaxel. Predefined, there was a first set of data on the Chartered trial, and in Stampede, this is our result, that for high Decipher patients, and this is a cutoff defined in metastatic patients, they're the ones who derive benefit from docetaxel. The low Decipher patients, that's on the right. So these are patients treated with ADT, red line, ADT docetaxel, green line. You can see the split of the lines in the high Decipher versus the low. So Decipher is prognostic, and more on that later, but it's also predictive. It's predictive of docetaxel effect, both in low volume patients and high volume patients. I can't not talk about blood tests, so really briefly. People always ask me about ctDNA. A single test that diagnoses ctDNA is not that useful. Alex will present tomorrow on this, but you can see from one of his previous publications, the majority of patients presenting with metastatic disease don't have ctDNA, or the levels are really low. So if you're going to try and take this test to localized disease, you're really going to struggle. And levels fall rapidly as soon as you start treatment. If you're 1 week late, after ADT has started, there's no ctDNA there. So I think we need to look at other tests, and this is one potential test. So plasma lipids, which Lisa Hovarts presented in an analysis on ENZAMET. Really interestingly, the test is both prognostic, but also predictive of no benefit of enzalutamide. So the negative patients, the patients with low levels of lipids or of the score, are the ones who derive benefit. So take-home messages. At least currently, tumor DNA sequencing is not useful for risk stratification or prognostication. It has utility in CRPC for drug selection, and I think we'll see that migrate to metastatic HSPC and down the line localized high-risk disease. Germline DNA testing, if you take one message home, do more BRCA testing, implement that in your practice. From the current evidence, mRNA profiling is giving us much more information on risk stratification and the disease behavior for patients with advanced, very advanced and metastatic disease. ctDNA I've alluded to. I haven't talked about novel imaging and molecular tests. We have no data to understand the added value, but I'm sure we'll debate that over the course of this day and a half. And finally, I think we need to try and convince payers to accept Simon's level 1B evidence and not restart trials from scratch to prove the molecular test is of utility. So if we can work together, run the same test, using the same approach across multiple trials, that should, I hope, lead to clinical implementation for our patients. Thank you.